All right, we can go ahead and get started. I see the numbers kind of stabilizing there. Welcome everyone to back support configuration for optimal scapular and pulmonary function. This is IC29, and our presenters today are Eleni Halkiotis and Brenlee Mogul-Rotman. And I will turn it over to them now. Feel free to put your questions in the chat. We will sort of monitor it throughout and definitely leave a little time at the end to answer those questions. I will also be putting the CEU code in the chat and stating it verbally at the end of the course.
Awesome. Thank you, Julie. Thank you, everyone, for joining us today. Hope you've had a good day so far. We're almost at the end of our day, so hope everyone's still doing all right. My name is Brenlee Mogul-Rotman, and my co-presenter, hold on, I'm just still trying to figure out my slides here. There we go. And my co-presenter is Eleni Halkiotis. Both Eleni and I are occupational therapists. We both work at Permobile. Eleni is in New York City, and I am in just north of Toronto in Canada. So our disclosure is exactly that we are both full-time employees at Permobile as clinical education managers. However, we just want to make sure that you guys know that this presentation is in no way specific to Permobile products. It is a generic presentation. So I hope that is all good and clear. So the objectives for this presentation, as you know, because you signed up for them, is that we will describe the anatomy and kinesiology of the scapulae in relation to propulsion and reach for mobility-related ADL performance. We will ensure that you can identify 4 features of back supports and summarize how the clinical application of these features can impact both functional reach and propulsion. And we'll also make sure that you can specify 3 back support characteristics, which can help to enable optimal pulmonary function in populations with respiratory dysfunctions. So let's start with a quick review of posture and positions and the importance always of completing that full client assessment, both on and off the mat, in order to determine the client's presentation, their tendencies, and any deformities that may be present. We all know that the pelvis is the key point of seating and that the upper body and the lower body are going to follow the pelvis when it comes to alignment and positioning. The spine protects the spinal cord, obviously, and enables the trunk mobility. We know that the spine's the connector of the upper and the lower body. All right, so that's our little bit of anatomy for you, not too much today. When we're looking at the ideal posture, we know that we want the spine to be upright, midline, and have its normal curves. We'd like to see the pelvis midline in all planes and somewhat neutral if possible. We would like the femurs to be parallel to the seating surface so that the feet can sit flat on foot plates. And we'd like the head to be upright and midline also to allow the client to see the world around them. So when something is off or something changes, it's important really to best determine what it is that has changed and the effect of that change on the entire body. Is the cause of the change at the pelvis, or did the spine change, creating a change at the pelvis? Sometimes we know what part of the anatomy caused the change, but sometimes we don't. Determining if we have reducible or non-reducible deformities is paramount. And we also need to remember, if we modify one part of the body and its position, then we're definitely changing a bunch of other things as well. So when we're looking at our seating components, it's important to remember that just changing the cushion isn't enough to fix a problem. We need to consider the other body parts, the trunk, the extremities, and ensure that we're providing support, stability, and positioning for function through the client's entire anatomy. The optimal seating mobility system includes seating components in conjunction with mobility base. And together, that's going to create that system. So we hope that that system together allows the client to achieve postural stability, allow for pressure redistribution, and attain the best postural alignment that we can get for that particular client. So today we wanted to talk about back supports. So let's get into some of the specifics about back supports. Firstly, we have to, again, go back to the assessment of the client and make that determination of whether we are correcting or accommodating whatever deformity we happen to see. So is the person's deformity, and in this picture, you're seeing pelvic obliquities with associated scoliosis, is the deformity reducible or non-reducible? And to what extent? So we know that we can't always correct an entire deformity all in one shot. We might have to do things very slowly, or we might not be able to do any correction at all. We also need to determine how much force is required to support that individual. So Anthony on the left is a low-level paraplegic with abdominal and trunk muscles working. He requires very minimal support, and you could see that if you were behind him and had your hands on him. The young lady in the middle has significant amounts of high tone and spasticity, which definitely cause her to lose that upright position. She requires pretty significant support when her spasms occur. She requires support, but more minimal on the opposite side that she falls to when she's able to rest back or be positioned back into that more upright posture. So the force of what she needs is asymmetrical, and it's different on both sides. And then the client on the picture on the right really requires the most significant amount of support to accommodate his non-reducible and very significant multiple deformities and curvatures. You're going to determine how much trunk support is needed through your simulation and your hands-on during your assessment of the client. Oops. Let's try this again. There we go. So once we figure out what our client issues and needs are, then we've got to translate this to product features or characteristics. A back support consists of a shape and a contour of the shell, an inside medium or material, and then the possible adjustability that's going to be available through the hardware. So let's go through each one of those. There's various shapes of back support shells. The back shell can incorporate lateral trunk contour at various levels and with various amounts or depths of contour. The posterior aspect of the shell can be flat or it can be open. If it's open, that can allow for enhanced immersion into the back support posteriorly, and that can help with managing seat depth. It can help with managing contact with the material within the back support as well. And a posterior planar back shell can allow for growth or change often because the flat shell often can accommodate internal supports or wings that can get that anatomical contact that we need with the client, but still be adjustable as the client changes in size, or a pediatric client who's going to grow. Functionally, we want to make sure that the client's able to sit in a stable position, but also move to perform activities. So when you're looking at the shape of the shell, make sure that the shape doesn't interfere with the client leaning to the side for reaching or transferring, or the shape of the shell doesn't interfere with scapular movement that's going to be needed for propulsion. So it's really important not just to look at the client in that static seated position. You've got to look at them, let them move around and let them do some of their functional tasks, because you might think that they're sitting beautifully, but then they go to lean over to the side to reach something and they realize that we've put too much contour and they're locked in place. So we always know that there might be that compromise between alignment and function. And within the back shell itself, we're going to have various options related to the medium or the material of the padding. So we know that quality foam can allow for good immersion and envelopment of a person's shape, can provide comfort and some pressure management. We want to be cautious with foam of potential shear and friction, as well as the holding of heat. With fluids allow for immersion and envelopment for pressure redistribution, which we know. Fluids can be air or viscous fluids, can be flowing or non-flowing fluids, and they can assist with shear and friction reduction. And depending on the type of fluid that might be used, there might be some setup and maintenance required over time. Elastomers or gels can assist with temperature maintenance and some shear friction reduction. And depending on how they're utilized, they might provide some immersion as well. And then our hybrids of materials usually pair one of the other mediums with foam, usually, not always, but it's usually foam and something else. And often stability from the foam with the pressure management properties of the fluids is the most common, and that's going to provide you immersion, shock absorption, air circulation, and shear friction reduction. So that's what we see with our mediums. We know that comfort and pain management is often addressed with the choice of medium. So for example, a client with hardware surgically embedded into their spine, or maybe those clients with surgical scarring or a gibbous might have some pain issues, and a different material might help to manage that pain. Other issues such as bony changes or joint and bone fragility can be addressed and possibly mitigated through the correct choice of a material. And the material may also affect the client's ability to breathe. And Eleni's going to discuss that in much more detail a little bit later on in the presentation. All right, so after we talk about the mediums, let's talk about some adjustability of back supports, and we'll start with the height and the length. Height is where the back support is mounted on the chair. Length of a back is how tall or long the back support is. So they're two different things. The key landmark when deciding where to mount, oops, what's going on here? The key, what just happened to my slide? There we go. All right. Oof. So remember that the key landmark when deciding where to mount a back support is the PSIS, posterior superior iliac spine. So that way we're going to make sure that we're providing lower trunk control and control of the pelvis as well. So if the client needs more trunk support, they need a taller back, they need the back higher up, we don't want to just take the back and move it up, because then we're going to lose that PSIS. What you want to do is don't mount it higher, just get a taller or an increased length of your back support. All right. And in a study in 2012, Yang et al. Stated that higher backrests do provide more support to the spine and head, obviously, but can impede the range of motion of the upper arms during ADLs. So they made the comment that active wheelchair users who need more trunk support and who also self-propel are challenged by determining the height that provides the best balance between support and function. So it is something very important to look at, again, that potential compromise. And we always try to go with, let function win, but we also need the client to be stable and positioned in order for that function. So there might be some compromise, but you know that the functional implications you can see for the height and the length of backs are listed there. Depth of the back support is how forward or rearward the back is mounted on the wheelchair. And this is definitely going to affect the seat depth as well. If you adjust one, you're going to have to adjust the other one. And it's important to ensure that if you adjust the depth of the back, check your seat depth and also check your center of gravity. So make sure that's adjusted on the wheelchair. And you also want to look at the client to make sure that their center of mass or their body weight is distributed correctly over the wheelchair base so that they have adequate access to the rear wheels to propel. So it can really give these functional benefits, but you've got to make sure that you've got everything adjusted. Like I said before, if you adjust one thing, you're going to have to adjust sort of everything else at the same time. And lastly, the adjustment of seat to back angle. And the angle can cause the client to sit anterior, neutral, or reclined. An open seat to back angle is more of that reclined position, and a closed seat to back angle is more anterior or forward. And the correctly adjusted back support angle is going to ensure that the client is still in contact with the back support and that gravity is assisting with positioning as needed, so that you get that stability and balance if the client needs it. And sometimes the angle of the back requires minimal adjustment, but might make all the functional difference that a client requires to be able to complete all their daily tasks and participate in activities. Thanks, Eleni.
You're welcome.
And then customizing a back shell or the medium allows for increased accommodation or correction and the ability to potentially lock the client into a safe and stable position. The client's shape and their size can really be intimately matched through customization, and skin and tissue protection, as we know, can really be enhanced, as well as positioning. And functionally, customization provides an opportunity to enhance stability, posture and positioning, perhaps pressure management, body functioning, and functional activities during their, their daily tasks. So you really do need to look at, can we do the off the shelf with some adjustability, or do we just not have enough and we need to go custom? And then don't forget about secondary supports. These really can be essential components to the entire seating system and can assist in providing more support, more stability, and positioning for function. And secondary supports are available and should be considered for every body portion of the client's body in that seated position. Oh, what happened, Eleni?
I go ahead and share my screen and I'll get started. Okay, now we're going to review scapular kinematics as they relate to manual wheelchair use and propulsion. Thing has a mind of its own, but we're going to do our best to just proceed. I don't know why it's all over the place. Okay. So the scapulae are two wing-like bones that link the spine to the upper extremity. And because of this linkage, the scapulae are truly the origin of proximal upper extremity movement. The scapulae are positioned approximately 5 centimeters lateral to the thoracic spine between T2 and T7, and the scapulae lay over the thoracic spine at an anteriorly tilted level. The thoracic spine themselves has a convex curve, which is between 20 and 40 degrees in the average person. And scholars argue that the scapulae lie at an anteriorly tilted angle between 5 and 15 degrees. And as the degree of kyphosis increases, for example, going from the normal thoracic kyphosis to a hyperkyphosis, so does the position of the scapulae laying over the the thoracic spine. And I'm not sure if Chuck or someone from IT can help with this. It keeps jumping around and I'm not sure why. But we'll keep going on. So the scapulae have 3 joints. We have the glenohumeral joint, the acromioclavicular joint, and the scapulothoracic joint. The glenohumeral joint is the most common joint that we think of when we're considering the shoulder. And the glenoid fossa for the glenohumeral joint is part of the scapula. So that's the integral part of our shoulder joint where we get 180 degrees of range of motion. The acromioclavicular joint is the second scapular joint, which is really the connection between the scapula and the clavicle. And that joint is responsible for shoulder rotation. So internal rotation and external rotation. And the acromioclavicular joint also works to help to distribute force from the upper extremity into the clavicle. And the third joint we're going to talk about, the scapulothoracic joint, is not a true joint in the sense of the word, but really it's more of an interplay between the scapula and the thoracic spine. And it's connected to the thoracic spine through the subscapularis and some other musculature. And through these joints, we are able to control proximal upper extremity movement through the shoulder joint. And that's why if a client's scapular position changes, they have a winged scapula, they elevate their scapula, it will change the position of the glenoid fossa and in turn affect the range of motion through the glenoid humeral joint. Going to play a couple videos here that have no sound, but this first one demonstrates from the skeletal level what shoulder flexion and extension looks like. And keep an eye on the scapula and notice how much movement is really going on there. Consider someone who's propelling a manual wheelchair and they need to reach back on the wheel to 10 o'clock and push forward, and noticing how much range of motion is going on in the scapula and in the glenohumeral joint to make that happen. And the second video I'm going to play also has no sound, and this is more about scapulohumeral rhythm. If you're working with a client and they are sitting in a wheelchair that's far too wide for them, or the wheels are just mounted laterally to the extent that they need to abduct their shoulder beyond 30 degrees, well, it's at 30 degrees of shoulder abduction where the scapulae begin to rotate. And that being said, it will throw off the whole scapulohumeral rhythm and the biomechanics of propulsion if the client is trying to push a wheelchair where their wheels require them to abduct beyond 30 degrees. And it's another reason why when we are configuring manual wheelchairs that we want to bring the wheels in as close as possible to the client so that they can have much more ergonomic and efficient propulsion. So we've talked about the skeletal level. The next thing to consider is the musculature. And one muscle that I want to point out in particular is the Latissimus Dorsi. The Latissimus Dorsi is a massive muscle. It has origins spanning from the pelvis, from the pelvic iliac crest, through the lumbar and thoracic spines, L5 up to T7, through the thoracolumbar fascia. It has an origin on the lower 3 to 4 ribs, the inferior angle of the scapula. And after all these origins, it has a singular insertion on the bicipital groove of the humerus. And that's why those of you on the call, you can try this out yourselves. You sit up in a neutral posture with your pelvis in neutral and sitting with upright trunk posture, and then try to raise your arm. You can raise your arm all the way, 180 degrees of shoulder flexion. Whereas if you collapse into a posterior pelvic tilt and have a rounded trunk posture with a hyperkyphosis in your thoracic spine, and then try to do the same movement, you will notice that you are limited. And that is at least in part related to the Latissimus dorsi, because when you are sitting in an upright neutral posture, you have more excursion and length of the muscle that you can utilize to flex the shoulder all the way up. Whereas when you have collapsed posteriorly into that posterior pelvic tilt and the thoracic hyperkyphosis, the Latissimus dorsi is pulled more in a downward position, and you do not have more excursion to raise your arm further up. And think about that for our clients, manual wheelchair riders that roll into clinic, that have collapsed into a posterior pelvic tilt, that are sitting with a really kyphotic posture, and then expect them to do any sort of mobility related activity of daily living requiring forward or overhead reach. They really are put at a biomechanical disadvantage for those reasons. To review, optimal alignment is where we have a client sitting with a neutral pelvis, meaning they're bearing weight through their ischial tuberosities, but it's neutral front to back, side to side, up and down. They are not bearing weight on the sacrum or the coccyx when they're sitting in a neutral pelvic posture. And that works its way up the chain to the lumbar spine, where we see the normal concave curve. The lumbar and the cervical spines are where we see a normal concave curve, and then the thoracic spine is where we see the normal kyphotic curve, which as I mentioned is between 20 and 40 degrees in the average person. But when a client is positioning themselves with a posterior pelvic posture, posterior pelvic tilt, we see the PSIS lower than the ASIS, and now they are also weight bearing on their coccyx and their sacrum, in addition to the ischial tuberosities. This postural asymmetry has worked its way up the chain to flatten the lumbar spine. No longer do they have that normal concave curve in the lumbar spine, but instead it's flattened, and this asymmetry has worked its way up the chain from the pelvis to the lumbar spine to create a hyperkyphosis, what we often call in the clinic just a kyphosis, but really it is a hyperkyphosis of the thoracic spine. And that can certainly affect line of sight and head position as well. A study was conducted in South Korea and published in 2018, which investigated the relationship between hyperkyphosis and forward scapular posture. The study investigated the effect of thoracic extension exercises on a group of 10 able-bodied participants. These participants all had a hyperkyphosis of greater than 40 degrees, and they were given 2 exercises to complete for a course of 12 days straight. And the exercises were specifically to reduce the extent of their hyperkyphosis. They were thoracic extension exercises. And the hypothesis was that by reducing the hyperkyphosis, scapular position will be improved and it will be more retracted. And they indeed found just that only after 12 days of doing 2 particular exercises, not only did the degree of kyphosis become reduced, but also scapular positioning became improved. And on the right, we have photos of the device used to measure the scapular forward position, the palm meter. And although the study was conducted on able-bodied participants, I do believe that we can translate some of the findings to people who use wheelchairs, because if we're working with clients definitely who have a reducible kyphosis, and we can utilize a back support that does reduce their kyphosis to allow them to sit in a more upright trunk posture, then we can in turn improve their scapular position. And as we know, the scapula is directly related to upper extremity, especially proximal upper extremity movement, and enhance their function that way. When we're considering applying this to practice, we want to think about the type of back support we would utilize to optimize thoracic and scapular positioning. Certainly starting with a back support that has a rigid shell will assist to provide much more support than your tension adjustable upholstery or something like that. Consider adjustable components that are offered with some back supports that have a rigid shell, because the adjustability in, say, reels and aluminum stays can really help to sometimes fill in the lumbar spine area, which in turn can help to reduce the extent of the hyperkyphosis in the thoracic spine and give the support where it's needed based on different sort of postural asymmetries. Back supports can be ordered in different lengths, and some of them have contour to clear the scapulae, even if they are a little longer in length, and you can certainly order the length necessary for the support and propulsion needs of your client. And now we're going to have Brenlee talk about back supports for posture, function, and respiration.
Awesome. So I just requested the control of the mouse again. I just noticed as you were talking, Eleni, along with the other little technical issues, I just think it's funny that somehow my ISS background is backwards. But I was like, so I'm sorry to ISS, but my background's all messed up. So I'm not even going to attempt to change that. That could ruin everything. Anyways, just a little bit of lightness during our presentation. So what we want to do in this part is give some practical examples, give some examples of how the different features of the back supports make a difference to how our clients do what they need to do throughout the day. So we'll start with an example of both back support height as well as angle. So in this first image, what you see is the client, she's sitting, the background looks accurate to us. Fantastic, it's backwards to me. That's great to know. The client's sitting pretty straight, but you can see she's sitting a little bit of an open seat to back angle. She's falling over the back of the back support a little bit. And both of these issues are going to put her at a disadvantage for forward reach as well as propulsion. So she's fighting gravity every time she wants to reach something, every time she wants to engage. If she wants to give somebody a hug, she's fighting gravity. When we close up her, the seat to back angle, just a few tweaks, you can see she's sitting more upright. So she's in a more neutral posture. The back angle is closed more and the back is mounted more appropriately so that she's got better thoracic support. She's not falling over the back of it. She's definitely more upright. Her body mass is better positioned over the rear axles of the manual wheelchair. So we know that she's going to have better propulsion as well. And then in the last picture, you can see how she's able to reach with ease and hand a box almost overhead to her coworker there. She's got such improved back support positioning. So her scapulae are clear, her mid and lower back are supported. And from this proximal stability, she's really maximizing that mobility of the upper extremities that's going to allow her to do her functional tasks. When we talk about efficient propulsion, Basically, it requires optimal configuration and setup of the manual wheelchair, as we know. And so for optimal maneuverability of the manual chair, we'd like to see fewer push strokes, more coasting between the strokes. Longer push strokes allow that wheelchair rider to get stronger and have a more effective stroke. And then the propulsion pattern obviously makes a difference as well. So in this empowerment, it played already, but in the Empowerment Project training video, and they have some really cool training videos, they're recommending, oops, let me go back and see if I can play the video again. They're recommending the oval propulsion technique, strong, long pushes without maintaining hand contact of the pusher in between the strokes. So it is something to look at when we're talking about propulsion. And what we have to think about is not just the configuration of the manual wheelchair itself, but also that back support and how the person's able to sit upright. If the wheelchair itself isn't configured effectively for the client and their back support's not positioned to enhance that configuration and position them over the rear wheels and give them good access to the wheels, we know that we're not going to get optimal propulsion. So with the Consortium for Spinal Cord Medicine for PVA recommends that to get the best wheel access and push from propulsion, we want, I'm going to read these angles here. We want the client's elbows to be flexed between 100 and 120 degrees when the hand is at dead center. And the center of gravity configuration, the rear wheel position, the rear seat to floor height, and the back support angle are all going to affect how effective the propulsion is going to be and how much we can mitigate or minimize excessive stress and strain on the shoulders. And then back to the study from 2012 by Yang et al. And I know it's a little bit of an older study now, but there's not that many. It talked about, it's called the effective backrest height on wheelchair propulsion biomechanics for level and uphill conditions. And they had participants propelling on a treadmill, both level and uphill. And they either used a back support of 16 inches tall or 16 inches in length, or a lower back support that was measured at half the dimension of the client's trunk height. And the results concluded that pushing with the lower backrest length enabled greater range of shoulder motion, increased stroke angle push time, and reduced amount of strokes, whether the treadmill was flat or whether the treadmill was sloped. And though we know that using a lower back support for optimal propulsion and less risk of upper extremity stress and strain, we also know that we have to really think about, is that lower back support providing enough support? And so again, you need to look at beyond propulsion, look at the other activities of daily living, look at the other things that the client is doing in the chair, because again, it brings back that compromise. We need the client to be free to propel. We know that a lower back support is going to do that probably better. But is it going to give them enough support to allow them to do the other things like reach, like putting something forward, like doing everything else that they do when they're not propelling the chair? So it is something to really think about during the assessment and really go through every client goal that you can to determine what's going to meet the majority of the needs to get that optimal stability and optimal function as well. And then when we look at the selection of a back shell, and then we start to incorporate some other things from the wheelchair itself. So in this case example, the client has a very significant non-reducible thoracic kyphosis. The only contact with the back really is the apex of her curvature. And as a result, you can see she's just looking down at the floor. By using an open posterior style back support, her curvature is accommodated with better support below and above the apex. So she's brought back into and beyond the back shell. And then the use of a horizontal chest strap as her secondary support also assists in a more upright posture for her. And then lastly, the addition of power tilt on her power chair really allows for more shoulder and chest muscle alignment and stretching and gravity assisted positioning. And what her husband found was when she was in this position, he could actually assist her with her lower leg stretches and exercises because she was positioned so much better. So you need to look at our caregivers' needs as well. And then this is David, another example of the open back shell, but also an open seat to back angle and the adjustability. So David, again, has a very significant non-reducible kyphosis. You can see that he's got an extreme curvature, also looks down at the ground. The back shell is open in the back, which allows that curvature to go back beyond the back canes, but also beyond the shell of the back. So you can see that he's got open seat to back angle and a bend in the back canes. And he's got adjustable hardware on the back support itself that allows us to angle the back a little bit. And then he's got the open shell posteriorly that really allows for that immersion. And what you can see is that he's sitting in his chair upright. He's not using any of the manual tilt on that chair, and he can still see the world around him. We haven't lost seat depth. We're allowing him to breathe, swallow, and interact with the world around him in a more effective way. I'm just going to give up control. There you go, Eleni.
Oh, I did it again. Here we go. Now we're going to discuss pulmonary functioning as it relates to the wheelchair riding population, and a few things about respiration. First of all, if you can't breathe, nothing else matters. Our muscles require oxygen to work properly. So if the client we're working with has compromised respiratory status, and perhaps that is being even more affected by sitting them in a wheelchair system that is really, really tight around their trunk, it can impede the client's ability to do the necessary lateral and posterior chest expansion to take deep breaths and to get sufficient oxygen to their muscles. Because without sufficient oxygen, muscles can't operate to their maximum potential. And that certainly can affect a range of body function, not the least of which is mobility-related activities of daily living and wheelchair propulsion. When it comes to respiration, there are several muscles involved. For inspiration, the primary muscles are innervated through the cervical region. So we have the diaphragm and the scalenes innervated at C3 to C5 and C2 to C7 respectively. And then we have the sternomastoid, which is an accessory muscle for inspiration, and that too is innervated in the cervical regions at between C2 and C3. Now, the muscles used for expiration are innervated in our chest and abdominal areas, and those include the intercostal muscles between T1 and T11, and the abdominal muscles, especially the transverse abdominis, innervated between T7 and L1. To breathe involves chest expansion and contraction. When we do inspiration, our chest expands, and when we do expiration, our chest contracts. And not only do we have chest expansion to the front, like seeing our chest rise up and down, but there is lateral and posterior chest expansion as well. And I'm going to play a video where a woman demonstrates how to measure chest expansion in an able-bodied male.
And you're going to be placing this under the axilla on top of the pec muscles on a male. So if you put your hands up, please. Okay, put your arms down. You want them to relax. You want to pull it very, very tight and get an idea of where it's going to move with about a half a centimeter as he breathes in and out. So he's at about 103. Now take a deep breath, as deep as you can. Let it go out. Goes up to 109. Okay, and blow it all the way out. When he blows it all the way out, you have to physically bring it in. So it went down to a 102. So he started at a 103, he went up to a 109 and down to a 102, which is 7 centimeters, which is definitely normal. Normal is 4 to 6 centimeters.
So as she says, it's normal to have 4 to 6 centimeters of chest expansion when we breathe. And we want to make sure that the back support selected in the wheelchair allows for freedom of movement for 4 to 6 centimeters of chest expansion. An excellent study was published out of the University of Pittsburgh in 2018, and it was led by Teresa Kreitzer and colleagues, including one of our keynote speakers from this morning, Dr. Brad DiCiano. And the study investigated the relationship between pulmonary functioning and the population of clients who use wheelchairs with the diagnosis of spina bifida. Spina bifida, as many of you on the call know, is a diagnosis that during embryogenesis causes a lesion, usually a lesion related to incomplete closure of the neural tube. And in this particular study, the population of people with spina bifida had lesions in their thoracic or lumbosacral regions. And due to this incomplete or lack of innervation below the level of lesion, people with spina bifida not only require wheelchairs equipped with back supports, but also suffer complications like pulmonary dysfunction and scoliosis. This target population of people with spina bifida was selected because over half of people with spina bifida have a scoliosis. Over 35% of people with spina bifida have a diagnosis of obesity, and many have incomplete innervation of their respiratory muscles. This incomplete innervation of respiratory muscles commonly results in pulmonary dysfunction to the extent that it becomes a source of morbidity and mortality. They also suffer pneumonia and respiratory failure, which has been identified as being the second and third leading causes of mortality, and restrictive lung disease, which is technically a predisposing factor for developing pneumonia. During this study, they partnered with the respiratory therapists at the University of Pittsburgh to have a range of pulmonary function tests completed. And these include inspiration capacity, or IC, which means the amount of air that someone can inhale, the expiratory reserve volume, or ERV, which is the most forceful amount of air above a normal breath that can be exhaled during a forceful breath out, and residual volume, which is the amount of air remaining in the lungs after the most forceful respiration. And each of these tests are conducted using a tool like what you see here in the images. The findings were divided according to level of lesion. People, the study participants who had a thoracic level lesion versus those with a lumbosacral lesion, and both of those were compared to the predicted normal, people without a diagnosis of pulmonary dysfunction. What they saw is that the findings reflected what many of us would have expected. The higher the level of the lesion, the lower their level of pulmonary functioning was, because they have less total musculature that's innervated required for breathing. And with lower level lesions, even towards the sacral region, lumbosacral regions, they too had a significantly lower level of pulmonary functioning as compared with the predicted normal levels that we see on the left side. And I like to bring this up because many times in clinic, if the client is not wheezing or complaining of shortness of breath or uses oxygen or something like that, we might not always pursue or ask a lot of exploratory questions about their pulmonary functioning. But just because the client might not be complaining about it, or to them it might seem normal, or to an OT or PT where, you know, many of us do not have this specialization, I mean, we're not respiratory therapists, they might seem to be doing all right. We still want to make sure that our interventions with configuring wheeled mobility systems that they're going to be sitting in and day out can optimize their pulmonary function. Then they took it a step further in this research, and not only did they compare pulmonary functioning between those with lumbosacral level lesions and thoracic level lesions, but they also compared it with the extent of scoliosis. People who had what they classified in the study as a mild scoliosis compared to those with a moderate or severe scoliosis. And certainly they found that people who had a higher level lesion, like a thoracic level lesion, coupled with a moderate to severe scoliosis, had lower levels for inspiration capacity and expiratory reserve volume, whereas people who had a mild scoliosis and a lumbosacral lesion had really the best performance when it comes to inspiration capacity, but also some restrictions with expiratory reserve volume because they do not have all of their abdominal muscles innervated to really contract and expire that air. And so they end up with extra air in their lungs and not being able to really blow all that air out. And that certainly is related to pulmonary dysfunction issues. But how does this relate to our wheelchair world? When we are selecting a back support for a client who has impaired pulmonary functioning and also scoliosis, we certainly want to address their scoliosis so that we can put their trunk and chest cavity in the most neutral posture possible so that the internal organs are optimally aligned to the best extent that we can. And a lot of times I know as therapists, we're focused mostly on the scoliosis and really not so much on the respiratory functioning. But I'm going to tell you the good news is there are some things we can do to promote both. With scoliosis, certainly exploring the contour of the back support that we are recommending. There are many different types of contours, and I'm going to echo what Brenlee mentioned in the coming slide. And don't be afraid to use secondary postural supports, for example, lateral trunk supports, along with perhaps a deep contour rigid back support to effectively manage the positioning requirements for the scoliosis. And then we have respiratory function that can, the good news, be really helped by your selection of medium versus air versus foam. So first we'll go over scoliosis management. You want to select a shell that's going to be rigid, so you have sufficient support, especially laterally. You can choose a deep contour back support if that is enough lateral support to correct or address their scoliotic posture. Certainly feel free to use lateral trunk supports as needed. A lot of times for people who have a C-curve scoliosis, a really great way to address that is through 3 points of control, where you have one lateral support at the apex of the curve, one lateral support contralateral and superior to the apex of the curve, and then down below for the third point of control, you have a hip guide or a thigh guide to be contralateral and inferior to the apex of the curve. Regarding pulmonary functioning, many back supports, I'd say, typically back supports come with a foam medium. You have your rigid shell, you have your foam insert, and then you have your cover. But you can get back supports that are a hybrid of mediums with foam and air, or you could get a back support that is made entirely of inflatable air cells. And this was discussed by Teresa Kreitzer in her work about the benefit of inflatable air cells regarding allowing more freedom of movement for lateral and posterior chest expansion as compared to traditional foam back inserts. And when we're thinking about normal being 4 to 6 centimeters of chest expansion, we want to use a medium within our back support that can promote this. We definitely don't want to send our clients home with back supports where they can never take a deep breath. But fortunately, with inflatable air, it offers a lot more freedom of movement than your traditional foam inserts. And I'm going to go over a little case example here where this is a woman who is in her 40s, lives with her parents. She has a diagnosis of cerebral palsy, but what's most noticeable is her asymmetrical posture. She has an S-curve scoliosis. She has a pelvic obliquity. She has a rotational component to her scoliosis. She has winged scapulae. I circled here because she has a history of skin breakdown on her left scapula. And she's also underweight. So her skin has become thin. She lives with her parents who are in their 80s, and they were doing the best they could to try to care for her in a chair that was really not properly configured, more or less sling back upholstery. But she was seen for an evaluation for a new system. And during that evaluation, they identified all of these different issues, that she certainly needed much more postural support. She needs a skin protection due to her multiple bony prominences, not just on her sitting surface, but also along her back. She's underweight, and making sure that we keep all of this in mind when selecting the most appropriate back contour and medium. And so this client was ultimately issued a Rojo Agility custom back support where the medium was made entirely of inflatable air cells, which provides skin protection through immersion and envelopment into the inflatable air cells to protect all these bony prominences along her asymmetrical, due to her asymmetrical posture. And also the height of the back cells could be configured to match and support her postural asymmetries as needed. Plus, think about the positioning of her lungs in her chest cavity, given this posture. She is certainly using accessory muscles to breathe, and we wanted to make sure she was positioned in a back support that not only provided some assistance for posture, but also gave her that freedom of movement for the posterior and lateral chest expansion she needed to be able to breathe. In summary, back supports help our clients get throughout their day by assisting them with propulsion, making sure the back support is low enough that it clears the inferior angle of the scapulae and supports the thoracic spine so that the scapulae are optimally positioned through an upright thoracic posture. Back supports can help or hinder transfers, which is why it's important for us to really evaluate and investigate what type of transfer strategy the client is using and make sure that we select a back support that works with their transfer style to enable them to be as safe and independent as possible. Consider needs for the client to lean sideways to reach. I was working with a client who had a new child, new baby, and then soon the baby was a toddler and he was constantly leaning over to pick up the baby, put him on his lap, put the baby down. So think about all these sideways reach activities that the client might need to be able to do throughout the day, and how the back support that is selected really does the best to meet their postural needs, but also keeps in mind function, because we certainly don't want to compromise function for posture. We want to support the posture as much as possible while maximizing their level of function. Are they doing any dressing or undressing in the chair, especially upper body dressing? And does perhaps the contour of the back support need to be a certain way to enable them to independently get their upper body clothing on and off? Are they doing any bladder care in the chair? For example, do they self-catheterize, and do they have to kind of recline and lean back? And what kind of trunk posture do they need to be in to perform that self-catheterization in the wheelchair? We discussed a lot about respiration and selecting a back support shell and medium that promotes posterior and lateral chest expansion for respiration. Speech and swallow is also affected through upright posture, so making sure we are considering those needs as well. Power seat function usage, are they using a lot of recline on their power wheelchair? And if so, do the lateral trunk supports or the deep contour of the backrest work with them when they recline, or do we need to adjust some of the mounting for that to interface properly? Transportation to a vehicle, do they drive a big pickup truck and they need something lightweight that they can load in and out of themselves? Do they never need to fold up their chair? And maybe that will tell us what type of hardware the back support is mounted onto the system with. If they never need to fold it up and they have a lot of tone and they're very heavy on their equipment, maybe fixed hardware would be most appropriate for mounting the back support as opposed to adjustable removable hardware. And hooking. Sometimes clients functionally need to hook their arm around the push handle, and considering what kind of strategies they use with this hooking technique to perform MRADLs. So we make sure the back support works with them and not against them. In summary, when you are specifying a back support for a client, certainly consider the contour of the rigid shell, the medium inside it. You have many options ranging from foam to air to other fluids to hybrids. Mounting, how the back support is mounted onto the back canes, which can be adjusted for height and depth and angle. And adjustability. These days, a lot of back supports come off the shelf, out of the box, with built-in adjustability, stays and reels, and there are a lot of things that we can now do with off-the-shelf products to allow for much more adjustability, especially anterior posteriorly within an open shell design, for example. all of that can lead us to improving our posture, function, and respiration for clients. So we're going to open the line up to questions now.
I checked a couple of the questions while you were talking, Eleni. I agree, Tamara had just commented to be sure with scoliosis to look at what's happening outside of the wheelchair and look at that 24-hour positioning. Totally agree. We need to look at how the client is being moved. What other places are they sitting in? And then certainly during sleep, are they only lying on one side or do they turn to the other side? Do they have any positioning components? So absolutely, thank you for that comment. I did say that the references are in this presentation and they are at the end, the last couple of slides, and we've included the handout so you'll be able to upload it or download it and save it. Absolutely. And then the one comment from earlier is, how do you manage a client who's a manual wheelchair user but wants a high back for support because they're more focused on the comfort aspect than the functional aspect? That's all during, my opinion of that is that's all during the assessment. We know what we would like to recommend for postural alignment and nice positioning and you know, optimal function, but then you also need to look at not only our goals, but the client goals and what they want to do. The ultimate end decision should be the client's decision. I think it's important from our perspective as clinicians is to give them the, if we do this, then these might be the implications if we do it this way. So if we have a taller back, it might get in the way a little bit of you propelling. However, if we go with a lower back, you might be able to propel better, but you might feel less stable. So maybe there's a training component there. Maybe there's looking at something that is some adjustability in the mounting that we could move it up or down a little bit without losing that PSIS. So all of those things I would think should be considered. So Eleni, I don't know if you have something else that you would consider for that one.
Yeah, I'd also say, you know, good is better, or better is good. Sometimes we have like really all these things that we want to be able to do with our client, and maybe they can only tolerate so much change with this new system. And it might be that we implement a few of those changes with this system, and then maybe the next chair, they are like ready to do a lot more, or even the next year, they come back and they say, you know what, I'm sitting in the chair more, I'm ready, you can get more aggressive with this back, we can even switch the back out, things like that.
Yeah, and Faith had a good comment that there are shapes of back shells that you can get a taller back, but it has more aggressive scapular cutouts. So you can still get that midline trunk support, and you can still have room for the scapulae to move in order to propel and to function. So thank you for that as well.
I did just want to share that the CEU code is posted in the chat. If you guys have a few minutes and people still have questions, we can keep going. But for those who have to leave, it is TVGNL1, and a reminder to take the survey on the site so that you're able to get credit for the course. I don't see any more questions, but if anybody wants to ask them live or type them in, you know, we have a minute or two probably.
And you'll have our contact information on the slides as well. So yeah, thank you. And thank you for staying with us with our little bit of technical issues.
Thank you very much, everybody.
Thank you, Julie, for helping.
Yeah, no problem. Sorry there wasn't any help with the Zooming.
No, that's okay. Eleni figured it out. Thank goodness.
Good, good. Excellent. And I checked and your slides are posted on the site too, so people can get that right now if they'd like.
Awesome. Cool.
Awesome. Thank you so much.
Yeah, thank you. Guess we'll log off.